There's always this lingering fear that, anywhere from 20 to 30% of us will progress to metastatic disease. And we have no idea really who that is or why that is and amongst those of us. And so we live with this fear all the time. And really the kind of the holy grail for us is, can we figure out a way to never become that 20 to 30%?
Welcome to Breast Cancer Breakthroughs. Research for early breast cancer falls into two major categories: de-escalating treatment for those who have less aggressive breast cancer, and escalating treatment for those who have more aggressive breast cancer. You just heard from Tracy Cushing, who was diagnosed with early estrogen receptor-positive breast cancer in 2021. While outcomes for most people with early breast cancer are very good, Tracy explained that there is a lingering fear that patients face not knowing if their cancer will come back. Because unfortunately, everyone is at risk for recurrence, and this risk will vary greatly from person to person. Doctors don't yet have a good way of pinpointing who exactly will experience a breast cancer recurrence. In today's episode of Breast Cancer Breakthroughs, we will highlight the latest research that is setting out to prevent recurrence for people with early-stage estrogen receptor-positive breast cancer. You'll hear about this exciting research from experts in the field, Dr. Sara Tolaney and Dr. Aditya Bardia, and you'll hear more from Tracy on how patients decide which treatments are right for them. To learn more about the different stages of breast cancer, check out our video linked below. We focus a lot on metastatic breast cancer research because metastatic breast cancer is responsible for the majority of breast cancer-related deaths, and people with MBC desperately need more treatment options. But research on early-stage breast cancer is just as important. We asked Komen scholar Dr. Sara Tolaney to explain to us why.
Research in early-stage breast cancer is, in my mind, very critical because this is how we can help cure patients. So if we can get rid of the cancer when it's found early, we can prevent that cancer from coming back. And that is really critical. And so to me, that's probably one of the most important things that we can do is really to try to cure more patients and prevent patients from developing metastatic disease.
Early-stage estrogen receptor-positive breast cancer is actually the most frequently diagnosed type of breast cancer. And the good news is we are very good at treating it. In fact, the 5-year survival rate for estrogen receptor-positive breast cancer that's confined to the breast is 100%. But as we heard from Tracy, there is a risk of recurrence, and this can persist for decades. We asked Dr. Tolaney why patients with early estrogen receptor-positive breast cancer need more options.
So for a patient who has a hormone receptor-positive breast cancer, generally we know that hormonal therapies or therapies that will either decrease the amount of estrogen or block the estrogen are very highly effective treatments. And for some patients who have hormone receptor-positive breast cancers, chemotherapy can also be helpful in trying to kill any cancer cells that could be left behind, for example, after surgery. But we've learned that not all cancers are the same biologically. And so that means that some cancers, for example, are going to be very sensitive and get easily killed by some drugs, whereas other cancers may not be as sensitive to the treatments that we give them. And we've come a long way where we've tried to develop ways to personalize therapy to the individual tumor, and in fact have even learned how to send what we call a genomic assay to figure out which cancers may be sensitive to chemotherapy and which ones may not benefit from chemotherapy. But despite getting here and knowing how to utilize chemotherapy and hormone-based therapies, there still can be some patients who recur after having an early stage breast cancer, even after getting all those treatments. And to me, that means that we need to figure out better ways to treat these patients, and that thinking about what other therapies could help reduce that risk of recurrence is really critical.
Dr. Tolaney shared some of the most exciting new advances for people with early estrogen receptor-positive breast cancer.
It has been a really exciting time because we have seen several new therapies come out for early stage hormone receptor positive breast cancer. One type of treatment that I think has been really exciting for us to see come along is the use of what we call CDK4/6 inhibitors. So these are pills that can be given in addition to the hormone therapy for someone who has a hormone receptor positive breast cancer. And basically what this pill does is it's really trying to stop the cell cycle. So you remember maybe from biology classes where we learned that cells like to make copies of themselves. This drug, the CDK4/6 inhibitor, is not letting the cell make another copy of itself. So it's sort of halting that cell cycle. So in essence, if the cell can't replicate, it sort of falls asleep. And then hopefully when the cell's asleep for a really long time, it eventually dies. And so we've learned that when you add this pill to a hormone pill, it actually works synergistically. So it makes it work even better at killing the cancer cells. And there is a drug called abemaciclib. The brand name for this drug is Verzenio. And it was studied in combination with hormone treatments that were given to patients who had what we consider higher risk hormone receptor positive breast cancer. So breast cancers where there was lymph node involvement. And patients got their usual hormone therapies, but in addition to that, got 2 years of the abemaciclib added on. And when they did that, we saw that the patients who got the abemaciclib had a lot fewer recurrences than the people who were not getting the abemaciclib. And in fact, it reduced rates of recurrence by about a third. So it did seem to be a significant benefit for patients. And so it is a drug that we now consider adding to someone's hormone therapies if we think that their cancer is a higher risk cancer. And again, we would give that pill for 2 years in addition to the usual 5 to 10 years of the hormone pill. There's also another CDK4/6 inhibitor where we've seen more recent data come out. It's called ribociclib. This drug was studied in a trial called the NATALEE trial, where they gave 3 years of the ribociclib in addition to the hormone pill, and found that with the 3 additional years of this ribociclib drug, it reduced risks of recurrence by about 25%. The data is still a little bit earlier on than the data that we have from the monarchE trial, which was a trial that had studied abemaciclib. So it's not quite as mature, and we need to follow patients a little bit longer, but clearly also is showing a significant reduction in risks of recurrence. And so I think really important to see that we are making headway and that CDK4/6 inhibitors can help reduce risks of recurrence. So while we've seen new drugs come about like CDK4/6 inhibitors for hormone receptor positive disease, we haven't seen new endocrine drugs in the early ER positive breast cancer space for over 20 years. And so this is an area where I am excited because there are new drugs that are in anti-estrogen drugs in essence. So there's a new class of drugs that we call oral SERDs. And in essence, what these drugs do is they degrade the estrogen receptor. This is different than drugs that we typically give for early stage breast cancer, like an aromatase inhibitor, which really is working to get rid of the estrogen in a woman's body, whereas tamoxifen doesn't really allow that estrogen to stimulate the estrogen receptor. These new oral SERDs actually just chew up the estrogen receptor and don't allow it to signal. So it's a different mechanism. And for patients who have metastatic hormone receptor positive disease, we're seeing really exciting data that these drugs may be better than some of our standard hormone therapies. And so there are now trials exploring these oral SERDs for patients with early stage hormone receptor positive breast cancer. There are also other therapies that are getting explored to see if they too can help prevent recurrences. And one category of treatment that I think is super exciting is using what we call immunotherapy. So this is a type of treatment where, in essence, what we're trying to do is stimulate the body's own immune system to kill the cancer cells. And we've seen that this can be highly effective in some types of triple negative breast cancers. And so the idea was, could it also help hormone receptor positive breast cancers? And so there's some recent data that suggests that if you add immunotherapy to chemotherapy in patients who have high grade hormone receptor positive breast cancers, that we were seeing that if it was given prior to going to surgery, that the number of patients who had all their cancer gone at the time of surgery was a lot larger number of patients than compared to the people who just got the chemotherapy alone. We do need to follow these patients longer, though, to make sure that the immunotherapy is also preventing recurrences. And so we will need a little bit more time to see if that's the case. And if that proves to be the case, then this could be a treatment that we could consider for patients who have higher risk hormone receptor positive breast cancers. But I think, again, we need a little bit more time to flesh that out, but really exciting to see that these agents are moving forward.
As Dr. Tolaney said, data from the NATALEE trial has inspired hope that a new CDK4/6 inhibitor will soon be available for patients with early estrogen receptor-positive breast cancer. If you want to learn more about how CDK4/6 inhibitors work, check out our video linked below. Dr. Aditya Bardia is a former Komen grantee and one of the NATALEE trial leads. We asked him about this trial and what it could mean for patients.
The NATALEE trial looked at adjuvant ribociclib, which is a CDK4/6 inhibitor for patients with stage 2, stage 3 breast cancer. The goal of therapy in the adjuvant setting is to prevent recurrence and cure patients from the disease, breast cancer being the case in this circumstance. And we've seen very impressive results with ribociclib in the metastatic setting, where it has shown improvement in overall survival for patients with metastatic ER-positive breast cancer, with letrozole, with fulvestrant, both premenopausal, both postmenopausal setting. So the question was, can we use this effective drug in early breast cancer to prevent disease recurrence and increase the proportion of patients who have cure? So NATALEE looked at ribociclib plus endocrine therapy in the adjuvant setting.
The initial results of the trial were positive. Researchers found that 90.4% of patients taking ribociclib were recurrence-free after 3 years, compared to 87.1% of patients taking endocrine therapy alone. This translates into a 25.2% reduction in risk of recurrence. The most recent data from the NATALEE trial were just presented at the 2024 American Society of Clinical Oncology meeting. One aspect of the NATALEE trial that set it apart from the monarchE trial, which we mentioned earlier, was that it included a wider range of patients. Patients whose breast cancer was node negative were included in the NATALEE trial, and these patients were not currently eligible to receive abemaciclib for early breast cancer. The data just presented at ASCO showed that even patients with negative lymph nodes benefited from ribociclib, meaning that a new option may be on the way for these patients. However, with new treatments comes the risk of added side effects and financial toxicity. We asked Dr. Bardia about how patients can weigh the risks and the benefits.
Absolutely. I think everything is a risk-benefit ratio, and we need patient-centered discussion, talking about the benefit with the addition of ribociclib, and then potential downside, which would be adverse events. Ribociclib can cause increase in liver enzymes, so it's important to monitor that with blood test. It can decrease white blood cells, so monitoring with the routine complete blood profile is important as well. And then finally, this drug has a unique side effect. It's not very common, but a unique side effect of QTc prolongation, which is with an electrocardiogram, but something that's seen in the first 2 cycles. So when ribociclib is prescribed, usually physicians get an EKG in the first 2 cycles. The incidence is about 1% or so. It's not very common, but something to be aware of.
Tracy echoed these sentiments and explained that patients need to do what's best for them and that they should have conversations with their doctor about the goals of their treatment. She was one of those patients who needed to weigh the risks and benefits. CDK4/6 inhibitors were not yet available to patients with early estrogen receptor-positive breast cancer when Tracy was diagnosed. But because she had some risk factors for recurrence, she decided to ask her doctor about the CDK4/6 inhibitor abemaciclib when she saw the results of the monarchE trial.
There's a very long, contingency line of like where people fall on, I'm willing to go for this and I'm not willing to go past this in terms of my treatment. And so I'm one of the, I'll do literally just about anything. I was so young when diagnosed. I have a kid, I would rather live to a ripe old age and die of something else other than breast cancer if possible. And so for me, when I read the data, I brought it to my oncologist and I was like, hey, there's these drugs, they're CDK4/6 inhibitors. And in one of the trials, a high Ki-67 was one of the inclusion criteria, and that they saw a benefit for these things. And maybe that's me. Maybe I didn't have chemo but I still had an intermediate oncotype and this high Ki67. So maybe this is a way that we can reduce my risk given those things. And that was a totally new thing, that didn't exist at the moment I was diagnosed now 3 years ago. So that was pretty cool. But I really think that just asking that question at any point along treatment, right? Whether early stage, even metastatic, like what are your priorities, right? Because maybe it's not what your provider thinks is your priority. And it's really important, I think, to know that.
Ribociclib is not yet FDA approved for early estrogen receptor-positive breast cancer, and we're still waiting for more data. We asked Dr. Bardia what new questions the results of the NATALEE trial raises for doctors.
I think there are 3 important questions that the NATALEE trial has raised. The first one is, how would the results look like with additional follow-up with 3 years of ribociclib use, and what impact would that have on overall survival for a patient with ER-positive breast cancer? The second question is, are aromatase inhibitors the best backbone with the use of CDK4/6 inhibitor? Given the interest of oral SERDs, elacestrant, other oral SERDs, can those agents be used with ribociclib to further improve the outcomes for patients with ER-positive breast cancer? And the third is biomarkers. Do all patients need CDK4/6 inhibitor? Can we identify a subgroup that would derive more benefit, or vice versa, a subgroup that would not derive benefit? So we need more translational research to understand biomarkers to further fine-tune the benefits seen with ribociclib.
Dr. Tolaney agreed that longer follow-up and treatment personalization is crucial for not only the NATALEE trial, but for all clinical trials that are looking for new treatments for early estrogen receptor-positive breast cancer.
So I think when we're trying to develop treatments in hormone receptor positive disease, it's definitely an exciting space, but it can be tricky. And one of the reasons I think it has been challenging to shift the field is, one, thankfully, most patients actually do really well who have hormone receptor positive breast cancer. We, in fact, cure the vast majority of patients who have ER positive disease. And so that's, been fabulous. I think the challenge has been picking out those patients who are at higher risk of recurrence. And so can we figure out from the biology of the cancers which patients are those patients who are going to have their cancer potentially recur, and how can we prevent that? And so I think that's one of the areas that we've been really working hard towards, is trying to identify biomarkers to help us figure out which patients need additional treatments. I think the other challenge is that sometimes hormone receptor positive breast cancers can lay dormant for many years. And so sometimes what we see is that they actually can come back 10, 15, 20 years later, which is very different from other subtypes of breast cancer, which can recur much quicker. And so to study this takes a long time. And so that's not something we get quick answers to, which again makes it a little bit more challenging. We can't quickly understand which drugs are having benefit versus not, without following patients for many years. And so again, I think that's one of the challenges with getting new drugs approved, is it does take us time in hormone receptor positive disease to really see which drugs are having impact.
Thank you so much for watching. We hope you've come away feeling empowered to work with your doctor to make decisions on your personal risks of recurrence. Here at Komen, we are committed to bringing you evidence-based information to help you navigate your journey with breast cancer. Don't forget to sign up for reminders from Breast Cancer Breakthroughs. We've linked the homepage below. And finally, if you liked today's episode, please take 2 minutes to fill out our short survey, linked in the description below.